Hello and welcome to this presentation on understanding rate setting and cost-based interim payment methodologies for direct school-based services. This is Nicole Clark with the Medicaid SBS Technical Assistance Center. For today's webinar, we will cover the objectives and discuss more details around understanding requirements for billing and claiming SBS. Then we will move into a discussion around general considerations and the different cost-based methodologies. We will then move into a state-specific discussion with Colorado. We will conclude this session with a short Q&A and review some resources associated with the content of today's presentation. This webinar is intended to, 1, inform state Medicaid agencies and state education agencies about options for cost and rate-based reimbursement for direct SBS, and present considerations in implementing payment methodologies and rate setting. By the end of this webinar, you should be able to identify key considerations and action steps for developing payment methodologies, describe specific consideration for states using rate or cost-based methodologies, and describe best practices and lessons learned from states that have expanded SBS SPAs. In response to the horrific school shooting in Texas, Congress and President Biden developed the bipartisan Safer Communities Act that became law in June of 2022. The BSCA directed the Department of Health and Human Services to collaborate with the U.S. Department of Education to assist states on specific activities designed to increase access to school-based mental health services. Specifically, the law requires HHS and the Department of Education to issue guidance to state Medicaid agencies, local education agencies, and school-based entities to support the delivery of medical assistance to Medicaid and CHIP beneficiaries in school-based settings. At the same time, CMS and ED were tasked to establish this technical assistance center that's designed to assist states, state Medicaid agencies, school districts, and state departments of education to provide assistance under Medicaid. The task of the Technical Assistance Center is to reduce administrative burden and support school districts and school-based services for obtaining payment for Medicaid reimbursement and to ensure ongoing coordination between school districts regarding the provision and payment of Medicaid services. And one of the most important things was to provide direct assistance to rural and small schools that may have thought this was an activity that was beyond their reach. For Medicaid SBS, the BSCA specifically addresses establishing responsibility for interagency coordination between state agencies, providing SMAs and SEAs with technical assistance necessary for them to access Medicaid to provide SBS, and a special rule that identifies that the requirements may be met through state statute or regulation, signed agreements, or other appropriate written methods. For school-based services, there is a specific responsibility for interagency agreements at the state level. Today, we will have Michaela and Selena from the Technical Assistance Center presenting the upcoming sections. I will now pass it off to Michaela to talk through understanding requirements for billing and claiming SBS.
Thanks, Nicole. In this section, we'll provide some background information on the requirements for billing and claiming for school-based services, including state options for funding both the federal and non-federal share of Medicaid. This slide provides a high-level overview of the action steps, key stakeholders, and program documents that are needed to guide school-based service development and implementation. In today's webinar, we'll help you think through how to approach updating the two documents in the red box on the right, your state's payment methodology and cost reporting instructions. These documents are key components of school-based service financing and must be in place for schools to recoup the federal share of Medicaid funding. Updating or changing these documents will require collaboration between state Medicaid agencies or SMAs, state education agencies or SEAs, and local education agencies or LEAs. We'll talk more about the specific roles of each of these players in the following slides. Ultimately, your updated payment methodology must be documented in a state plan amendment or SPA and in the state-specific administrative and direct service guidance, including the cost reporting instructions that will be used by SEAs and LEAs as they begin providing and claiming for services. SEAs and SMAs should also review and, if needed, update policy guidance related to IDEA. Although Medicaid payment for school-based services includes both federal and non-federal shares, today we'll be focusing on financing the federal share in order to financially support schools throughout the year so they can continue providing these services to kids. Keep in mind that today's presentation is not a complete picture of how to finance school-based services. We are focusing in on the direct services component. The TAC held a webinar in October that discussed processes for claiming administrative services and preparing cost reports for end-of-year reconciliation. In addition, an upcoming TAC webinar on time studies will discuss use of administrative and direct service cost pools in greater detail. The methodologies we're talking about today need to be documented and approved by CMS as indicated in the red box on the prior slide. The state SPA and other associated documentation, which we'll talk about a little more about later in the presentation, should be submitted to CMS as soon as possible, but no later than June 1st, 2026, keeping in mind that SPAs must be approved before SMAs can claim for Medicaid covered services. This slide presents the different options that states can use to contribute to the non-federal share of Medicaid funding for school-based services. The first is certified public expenditures, or CPEs, which are a certification of funds expended to support a Medicaid service. The second is state legislative appropriations, which are general revenue funds appropriated by the state legislator directly to the SMA to pay for Medicaid and CHIP expenditures. And finally, intergovernmental transfers, or IGTs, are funds appropriated or collected by states or local governments that are transferred to and under the appropriate administrative control of the SMA and are used to support Medicaid activities as the non-federal share. Please note that IGTs can, but don't have to be, funded by state appropriations and have specific rules with no pay to play. This slide presents the three payment methodologies that states can use to claim for the federal share of school-based services. States using fee-for-service rates will generate reimbursement for school-based services by billing for each individual service using an existing community fee-for-service rate schedule. Or states may opt to develop enhanced payment rates for school-based providers. It's important to keep in mind that fee-for-service or enhanced fee-for-service rates must be funded through appropriations or IGTs, but not CPEs. In its SPA, a state using this approach will reference the community or enhanced fee-for-service schedule that will be used and be able to justify any rates that are higher than the community payment schedule. States using cost-based rates will reimburse providers for some or all direct school-based services on a cost basis through appropriations or IGTs, but again, not CPEs. Typically, states use the previous year's cost reports to develop cost-based rates, but may also consider provider salaries and overhead associated with services to establish a general cost per service amount for services provided in school settings. In its SPA, a state using cost-based rates must reference all rates that will be used for school-based services. Finally, states using a reconciled cost-based payment methodology will generate provider reimbursement for direct school-based services on a cost basis through CPEs that are reconciled at the end of the year. States will generally develop interim rates based on the prior year's cost or fee-for-service rates, with payments made throughout the year that are reconciled to actual cost at the end of the year using cost reports. This approach will result in a more complex payment methodology, which must be described in detail in a state SPA. The May 2023 State Medicaid Director's Letter introduced several new flexibilities for reconciled cost methodologies that we'll talk about a little later in the presentation. This slide presents several factors to consider when deciding on a payment methodology. First, you should consider which education services would be eligible for Medicaid funding that are not already financed by your state for school-based services. This will help determine the scope of changes that will be needed for your state's Medicaid plan. Second, consider how special education services are currently funded in your state. This will have implications for selecting a payment methodology for school-based services, as states using CPEs cannot use fee-for-service or cost-based rates and must instead use a reconciled cost payment methodology. In addition, you should consider how much cash flow schools in your state will need to provide services throughout the year. If schools need higher cash flow, a reconciled cost-based payment methodology may be best, since interim rates provide more immediate funding to offset the ongoing cost of providing or arranging services for students prior to cost reconciliation and settlement. You should also consider the reliability and accuracy of available school-based service payment data that will be used for rate setting. We'll talk more about this a little later. Finally, think about the level of resources, that is, the time, staff, and funding that are available to support development of the payment methodology and SPA documentation. If your state has minimal resources, using a more straightforward fee-for-service or cost-based rate approach may be best. SPAs for reconciled cost-based methodology are generally the most complex and will require the most resources from the SMA. Okay, great. So next we'll cover some general considerations as you begin to develop or revisit your payment methodology. So this slide highlights the general steps that your state will take after determining which payment methodology will be used. That is, whether you'll be using fee-for-service or cost-based rates or a reconciled cost-based methodology. The key steps include engaging stakeholders who will be involved in establishing the payment methodology, developing a timeline to make sure the methodology can be documented and implemented in a timely manner, gathering necessary data and using it for rate setting if it's needed, and documenting the methodology, including rates for a SPA. We'll go into more detail on each step in the slides that follow. So the first step is to engage a coalition that includes the key stakeholders who will contribute to rate setting and maintaining the payment methodology. In general, this will likely include the SMA, which will take the lead throughout this process with support from SEAs, LEAs, managed care organizations, and school administrative staff. If your state is establishing cost-based rates or carving school-based services into managed care capitation rates, you may also want to consider engaging your SMA's rate development team, which could include an actuary. This table provides an overview of the role each agency will take throughout this process. Again, for most steps, the SMA will be leading with support and information provided by SEAs and LEAs. However, when collecting data, the SMA could conduct an analysis of current claims data without asking the LEAs for help. However, the LEA's service documentation will provide a more complete source of information, or possibly the only information available if claims aren't being submitted. The next step for the coalition, again led by the SMA, is to map out the time needed to establish the methodology in advance of the school-based service implementation, keeping in mind CMS's June 1st, 2026 deadline. In creating the timeline, the SMA should consider the time needed to develop and document rates or reconciled cost-based methodology, including figuring out which providers should be included in time study cost pools, coordinating with key stakeholders, and applying the rates or methodology. We'll hear more from our state panelists in a little bit about how long it took for them to prepare their SPA, but for context, states should generally assume 6 to 12 months for CMS to review submitted SPAs and supporting cost reporting and payment methodology materials. States should also consider the time needed to collect data on prior year's costs, service use, and community fee schedules. Data points we'll cover on the next slide, which could increase your timeline by another 9 to 12 months. In the next step, the coalition will identify and implement a plan for data collection. Again, this should be led by the SMA, with LEAs and possibly SEAs providing data as needed to help with rate setting and establishing the methodology. We'll go into more detail on the data sources that may inform each payment methodology on the next slide. In most cases, LEAs and SEAs should contribute de-identified data for direct medical services, including MMIS claims data or service documentation, service logs, or expenditure reports. SMAs may also draw on cost reports and utilization data from a baseline time period if available, as well as community or cost-based rate schedules and other statewide historical data, including the number of children enrolled in Medicaid and possibly CHIP. Using complete and accurate data is important for establishing enhanced fee-for-service or cost-based rates and interim payments. CMS expects SMAs to make sure that reported costs and associated claims for FFP are accurate and represent only costs associated with delivering Medicaid services. If available data are not complete and accurate, SMAs should work closely with their SEAs and LEAs to improve the quality of data that will inform future review and updates to rates. SMAs may ultimately decide to use available MSIS or TMSIS data to fill in any gaps. In the final step of this process, the SMA will clearly document the payment methodology and rates in its SPA and the accompanying cost allocation plans. States using enhanced fee-for-service rates should also be prepared to provide justification that these rates are economic and efficient. After CMS approves these materials, the SMA should also update its internal claiming guidance for school-based services that will ultimately be provided to SEAs and LEAs. Also, please keep in mind that these documents should be provided to CMS as soon as possible, but no later than June 1st, 2026. This slide provides an overview of what should be included in the SPA and related documentation and what should be considered for conversations with CMS during the SPA review process. Keep in mind that these are the general requirements for a school-based services SPA. States should refer to the May 2023 Comprehensive Guide for a full description of what should be documented for their selected payment methodology. However, in general, each SPA should include a list of 1905A services, including but not limited to EPSDT services that are considered school-based services, and an assurance that these services are covered in the state's Medicaid plan. The SPA should also include a detailed description of the state's direct payment methodology. The complexity of this methodology, as well as the other documentation that the state should provide, will vary based on the selected payment approach. So we'll talk about these requirements in the following sections.
Thank you, Michaela. In this next section, we'll focus in on considerations for states that will be using fee-for-service rates for school-based services. Use of fee-for-service rates for payment of school-based services is the most straightforward methodology. States using this approach will often use existing community fee-for-service rates established for providers in non-school settings. With the May 2023 State Medicaid Director Letter, states were also granted flexibility to establish enhanced fee-for-service rates for school-based providers to account for the cost of delivering services in school settings. In establishing enhanced fee-for-service rates, the state should make sure it is using complete and accurate data sources, including community fee-for-service schedules for reference. The state should also consider the cost benefit of establishing rates that may be higher than community fee-for-service schedules. Finally, it is important to keep in mind that states using CPEs to fund school-based services cannot use fee-for-service rates to justify cost. The documentation required for a fee-for-service rate-based payment methodology is fairly minimal. The state must reference the relevant community fee-for-service schedule that will be used for school-based services, as well as the effective date of the fee schedule. If the state is using enhanced fee-for-service rates, it must also document the types of providers and services the fee schedules apply to. The state must also be able to provide justification that any enhanced rates used are consistent with economy, efficiency, and quality of care. An example of a state using community fee-for-service rates is Nevada. The state SPA referenced a fixed fee schedule for certain school-based services, with rates published on the agency's website. South Carolina is an example of a state using both community fee-for-service rates and enhanced fee-for-service rates for certain school-based services. Specifically, the state established an alternate fee schedule with the goal of expanding access to rehabilitative behavioral health services in school settings. The state SPA references a higher fee schedule for these behavioral health services and notes that all other school-based services are paid at the community fee-for-service rate schedule. In this next section, we'll focus in on considerations for states that will be using cost-based rates to pay for school-based services. In some cases, states may elect to establish cost-based rates that are specific to Medicaid school-based service providers to account for costs that the provider may incur when delivering services in a school-based setting. For example, due to the higher number of paid staff participating in the care of Medicaid-eligible students and the scope of services that could be included in a student's IEP. Using this approach, the state establishes rates for Medicaid-covered services and providers for a specific increment of time, using base period cost reports and utilization data provided by LEAs or SEAs. The state will then track provider services through submitted claims or by using another methodology that comprehensively tracks services. It is important to keep in mind that funding for cost-based rates cannot use CPEs since the actual incurred costs are not accounted for and there is no reconciliation process. Reimbursement for school-based services using a cost-based rate approach follows the general process shown on this slide. In most cases, the LEA will submit claims on an ongoing basis to the third-party administrator, which will in turn bill the SMA or relevant MCO. In some cases, the district processes their own claims directly to the SMA, but most will have a vendor that does this for them. The payment is then made to the LEA as reimbursement for services provided. The SMA must report actual costs to federal Medicaid at the end of each quarter by submitting their Form CMS 64. At the end of each year, the total amount paid will be reconciled with the state's authorized federal funding using the amounts claimed on the state's Form CMS 64 submissions for that year. When establishing cost-based rates, the state should consider the actual cost of providing services in the school setting based on the salaries and benefits of qualified providers, the medical supplies and equipment used to furnish services, and the overhead associated with covered services. Most overhead costs are determined by cognizant agency rates set by the SEA. To establish rates, states should use complete and accurate data sources, which may include LEA-provided information about the time and cost associated with common services delivered in schools, as well as service utilization data from claims or service documentation. Cost-based rates are usually set for a defined service type on a statewide basis. For example, a SMA could set a statewide rate for a 15-minute encounter with a physical therapist. However, in some cases, the state may determine it is more efficient to establish regional or LEA-specific rates, so long as the data supports the rates. For example, a state may elect to set higher rates for school-based services in certain areas where the cost of delivering services is higher. SMAs should periodically review cost-based rates and services provided to ensure rates are updated to reflect costs. SMAs should also keep in mind that cost-based rates are subject to federal cost rules. The state's payment methodology should include a list of the 1905A services encompassed in school-based services and an assurance that these services are covered in the state's Medicaid plan. The state should also reference the relevant cost-based rates that will be used for school-based services, including how the rates were formulated and updated for each service and providers, and which services are covered and at what billing increments. If varying rates will be used in different locations or LEAs, the state should also describe the methodology used to arrive at these rates. Finally, the state should explain when and how cost-based rates will be reviewed and updated. Oregon is an example of a state that uses cost-based rates to reimburse for 14 school-based services, with the state's portion of the funding provided through IGTs. The Oregon Department of Education requires each LEA to provide annual cost reporting as well as a Medicaid cost calculation worksheet, which is used by the state to determine a cost per minute rate for each service. The rates established include only minutes in which treatment is provided, and supporting documentation for actual service time is completed and maintained. Rates are established for each LEA based on the prior year's audited costs. If an LEA does not have the full prior year of actual costs to establish a per minute rate, the LEA can use a cost-based methodology for the first year. Finally, we'll talk now about key considerations for states considering use of a reconciled cost-based payment methodology using CPEs. States using this methodology will generally make interim payments to providers for covered school-based services throughout the year, then reconcile to incurred costs attributable to Medicaid in the cost report submitted by the LEAs at the end of the year. The interim rate effectively provides money to sustain the LEA for services provided during the school year before federal funds are drawn down. Generally, it is best to provide interim payments to LEAs that are close to or less than the cost of providing the service. Overpaying interim payments would mean that LEAs must pay back the overpayment to the state after reconciling costs at the end of the year. So to mitigate this, some states elect to pay out only a percentage of the services rendered based on how mature an LEA is. For example, giving large urban districts a 90% interim payment and giving LEAs new to participating in Medicaid only 80% of the interim payment. A few things to keep in mind. First, although the new school-based services guidance does not require LEAs to submit a claim to receive an interim payment, the requirement to document all services has not gone away. States need to tell their LEAs that they must still collect state Medicaid manual minimum documentation requirements, state IDA documentation requirements, and school-based providers must still follow documentation requirements required by the professional license. Collection of basic data metrics is crucial for the Medicaid program to monitor trends in care and support performance improvement across physical health, mental health, and substance use disorder services. In addition, states that use a reconciled cost-based payment methodology for school-based services must use CPEs, which certify that funds were expended by public entities for Medicaid services. For states in which school-based services are carved into managed care, schools will generally receive reimbursement on a schedule defined in the managed care plan contract. SMAs may modify managed care plan contracts to require reimbursement on an alternate schedule, but must adhere to the federal requirements for state-directed payments. For states in which school-based services are out of managed care, states may choose any of the payment methodologies we've discussed today, so long as it is documented in a SPA. SMAs may structure interim payments in multiple ways. For example, LEAs or schools can bill the SMA for services provided, and state Medicaid agencies can use interim payment rates, such as the fee-for-service rates paid to other providers or the lesser of the billed charges or the state's fee-for-service rate. Alternatively, an SMA can make monthly or quarterly interim payments to the LEAs on the prior year costs. Although states can decide whether interim payments apply to all LEAs or are LEA specific, it is generally easier for the state to apply the payment statewide. The May 2023 State Medicaid Director Letter introduced several flexible options for setting interim payment rates, which we will talk about more in the next slide. These include roster billing, per child per month payments, or bundled payments. This table presents the new flexibilities for interim payments introduced in the May State Medicaid Director Letter. The first is roster billing, in which the SMA creates a predetermined rate or uses the state's fee-for-service rate for non-school-based services, which is then multiplied by the number of Medicaid-enrolled students that receive covered services within a month or quarter. These payments are then reconciled to actual costs at the end of the year. The second is PCPM rates, in which the SMA creates a cost-based rate based on 1/12 of the provider's previous year actual costs that is paid out each month on a PCPM basis. Please note that this is not a capitated payment. A service would need to be rendered to trigger payment on a PCPM basis. The third is an average cost per service monthly interim rate, in which the SMA establishes an average per encounter rate that is based on the services that SMA anticipates will be provided on average in an encounter by an LEA. For example, billing could be based on an average calculation of expected costs per visit for several different types of services, such as occupational therapists, physical therapists, speech therapists, or nurses. Finally, the May 2023 State Medicaid Director Letter also clarified prior guidance to specify that bundled interim rates can be used for school-based services, so long as they are explained clearly in the SPA and the rates are reconciled to the actual cost at the end of the year. Bundled fee schedule rates that are not reconciled to actual costs or based on actual costs will not be approved by CMS. Michigan is an example of a state that uses provider-specific interim rates for its reconciled cost methodology. The interim rates are calculated based on an estimated monthly cost formula using prior year costs that account for inflation. Reconciliation of the interim rates is conducted after the final provider cost reports are reviewed and reported based on the fiscal school year. Providers can request changes in their interim payment rates by submitting written documentation of significant changes in coverage, service utilization, or staff costs. This figure depicts how Michigan's interim payment process and cost reconciliation process work together to provide reimbursement for school-based services. States seeking to use a reconciled payment methodology must include a detailed explanation of this methodology in their SPA. States should refer to the comprehensive guide for a full list of requirements. However, this will generally include a list of covered 1905A services, a description of their direct medical service payment methodology, their interim payment methodology, and annual reconciliation and cost settlement procedures. The state must also reference specialized transportation cost pools and allocation if applicable. In addition to these materials, the state is expected to discuss with CMS other relevant documentation during the SPA review process. This includes detailed cost reporting instructions for providers, a certification statement signed by a school or LEA official, and the state's time study implementation plan, PCAP, and other documentation as needed. The slide provides a little more detail on cost reporting requirements for providers. To determine the portion of school-based services that can be certified as allowable Medicaid expenditures, state Medicaid agencies generally require school-based providers to use a uniform cost report. LEAs must use audited financial statements as the first step to develop their cost reports. The audited financial statements include an adjusted trial balance, which lists all of the expenses incurred and the state and federal revenues received by the LEA. The balance is then transferred to the cost report and time study results, allocate Medicaid's portion of allowable costs. Time studies are an important step in identifying Medicaid allowable costs for states using the cost-based reconciled payment methodology and will be covered at an upcoming TAC webinar. States should plan to provide or discuss with CMS a detailed cost report package, including a cost report template and instructions for providers to assist in billing, reporting, and allocating costs. Although CMS will not approve the cost report package, these materials will be used to demonstrate consistency with the comprehensive direct payment methodology during a walkthrough of the state SPA between the SMA and CMS. Now I will go ahead and pass it back to my colleague Michaela, who will move into the state panel portion of today's event.
Thanks, Selena. So we're very excited to have two representatives from Colorado's Department of Healthcare Policy and Financing with us today to talk more about how Colorado has established and implemented their school-based services payment methodology. Shannon and Olga, would you each like to introduce yourself briefly?
I'm Shannon Huska. I am the Financing Unit Manager in Colorado. I oversee a variety of programs, including the School Health Services Program.
Hi, everyone. My name is Olga Genshin, and I am the Program Administrator for the School-Based Services Program here in Colorado, and I report to Shannon.
Great. Thank you both. And to everyone listening today, please feel free to submit any questions through the Q&A function in Zoom. either to our two panelists today or just about the content that you've just heard. We'll be keeping track of questions and we'll hold time for responses at the end of the discussion. So please keep them coming. So for Shannon and Ogle, we'd appreciate if you could take a few minutes to just talk about your state's payment methodology for school-based services. Just tell us a little bit about what you're using at this point.
So Colorado switched from a traditional fee-for-service interim claiming to a 1/12 methodology with a CPE program around 12/13. Sorry, I don't remember the exact date off the top of my head right now. But in fiscal year 2008-9, we went from a straight fee-for-service methodology to a CPE methodology. As was being described before, we had a variety of levels of payments or interim rates set up for different districts based on size, location, that stuff. And we were finding many of the districts ended up in a payback situation every year, which for a school district doesn't work very well. So we worked with CMS and changed our methodology to be a 1/12. We base our interim payments on prior year's cost reports. We use cost reports that districts have filed, so we're using that district or LEA's information to develop rates. The LEAs are required to submit claims in the MMIS system still. That does not change, but every claim they submit is paid at a rate of 0. We give them set monthly interim payments based on prior years, and then we cost settle at the end of the year.
Great. Thanks so much, Shannon. And I guess, if you could tell us a little bit about like your experience developing the 1/12 methodology, how long it took you, any key factors you considered, as well as who you involved during the process.
Yeah, it actually started with my predecessor, but it started with conversations with CMS and reviewing our state plan and how our methodology was described in our state plan. We have since changed our state plan because we've gone to free care, but the methodology and the reimbursement has remained the same. But we had conversations with CMS saying, this is what our state plan says. We interpret that we can go this direction. Thoughts, making sure we were doing something that seemed appropriate and, had those conversations, making sure we had the green light, ensuring that, yes, we're still going to make sure LEAs submit claims, that stuff. And then working with the LEAs, we worked with our vendor to develop a methodology and different levels, because as you can imagine, in a state like Colorado, we have some very big metro areas and we have some really small rural areas. So one methodology didn't fit all. Similar to what was described earlier, we decided, well, if you meet a certain threshold of consistent reimbursement, we're going to use that to say you're going to get 90% off the bat. We didn't want to give just everything up front because there are fluctuations that we can't foresee, and we know that they'll get the balance at the end of the day regardless. We just started with 90 and 80, initially 80% being the smaller and rural districts. And we did run into some hiccups, and with use of our stakeholders and vendors and everything, and just communicating with all the partners, we decided new districts too, because all their information needs some time to flush out. We would change it from an 80% down to a 70% the first 2 years. And that has actually really helped. We are finding new school districts or new LEAs because we don't have all the information. We're still ending up in payback situations. So that's really helped it. We monitor it mid-year, which is great because we get quarterly cost reports. They're for admin claiming, but we're able to use that information to help us determine if the direct service claim is in line or not. And then we can make decisions with districts like, hey, it's looking like you might end up being in a payback situation if we continue this. we can make a real-time decision and adjustment if necessary. We also allow districts at the beginning of the school year to adjust their payments down. And that has been helpful because sometimes, especially in the small rural districts, they lose one child means they're going to lose 4 providers. They just no longer have need. Like, that's a dramatic example, but it could happen. So that way, if they have changes in their roster that they know are happening, they can make adjustments. We don't allow them to adjust up, but we do allow them to become more conservative.
Great. And can you, I mean, I know that the SCAs and LEAs are, or at least one of them is providing the cost reports, but are you working with that, or did you work with them in any other ways while you were developing your methodology?
The LEAs, I mean, we have a really good relationship with our LEAs, and we work with them throughout the process. I think with this methodology, it was kind of like, here it is, but actually, sorry, I'll take that back. We did. It was one of those areas that we found after the first year wasn't quite making sense. Some LEAs have a trajectory of a steady increase, but if that steady increase was greater than 10%, they actually got dinged for it, which wasn't really consistent with what we were trying to do. So we worked with the LEAs. They actually identified the issue and pointed it out to us. So we worked with them to find a better way to use that.
That's great. And I might have just missed this, but did you say about how long it took you to get this methodology in place? I know it was sort of a 2-phase process over the course of time, but just a general ballpark.
Yeah, I would say about a year to get the initial methodology up and running, because we implemented it at the beginning of a school year.
Okay. I think you had mentioned that working with vendors presented some challenges along the way. Were there any other challenges or barriers that you encountered during this process that you want to tell us about and how you overcame them or addressed them?
Yeah, and I would say I don't think working with their vendor was a challenge or a barrier at all. They actually helped us quite a bit. I would just say, communication is a change and it's different than the norm. So it took some education to LEAs. They were very much in the mind of fee-for-service billing, and we had just switched to cost-based. So they were still struggling with the difference between fee-for-service and cost-based, and now we're changing even how the claiming works. It has its benefits. The districts are able to more appropriately budget and monitor their funding as it's coming in, but it's a mind shift, and it took some time. So it was really some training and that type of stuff.
Got it. Thank you for clarifying. Any other challenges that you experienced, or was that the main one?
With the One Health, honestly, we lost some districts when we were strictly fee-for-service interim claiming. I think the challenge now is to get back to those districts that left during the time period. And I'm sorry, I keep saying districts, the LEAs from a national perspective. But getting those LEAs to listen and hear how it's changed and how this methodology does allow a much closer monitoring and flexibility for them.
Great. We are starting to get some questions for you in the chat, but I did just have one other sort of broader question that I was hoping you could speak to, is just if you had any advice that you would give another state that was embarking on this effort.
I think Olga would echo this too. I would say anything we do and we embark on is clear communication with all parties involved, being, the education agency, the stakeholders, the LEAs, just everyone. The more open and honest we are with everyone, the better success we have found.
Great. Okay. Anything else that you'd like to tell us about your payment methodology before we ask you a couple questions from attendees today?
I cannot think of anything. Olga, anything you?
I would just also say that other states can rely on the knowledge and experience of states. So reach out to us or other states with similar methodology. You don't have to just start from nothing. And the other thing I think I would add is that every year when our LEAs get their interim payments letter, we have a really in-depth explanation for the methodology that's used. So every year, like Shannon was saying, they can always reduce their payment if they know that their costs are going to decrease. We give them that opportunity. And at that time, they get that really in-depth letter of what their specific LEA payment is and how it was put together. So I think that's really helpful for them to understand the methodology as well.
Great. Thanks so much. And just a reminder to folks in the audience, please, we have about 10, 15 minutes for questions. So please feel free to chat them in and we'll try to get through as many as we have time for today. First question that we received for Colorado is how many LEAs you're overseeing?
I'm going to let Olga answer this one because she knows the statistics better than I do.
At total, we have 82 LEAs that participate, but we have 59 contracts. Some of those LEAs they participate as a Board of Cooperative Education Services or a BOCES. So although we support those 80 plus LEAs, we don't have as many contracts because some of the smaller districts elect to participate as a BOCES.
And we have 178 LEAs in Colorado, but of the ones that do participate, it makes up 89% of the student population.
Right. So really the ones that don't participate are those really small rural districts. Yeah.
Great, thank you. Another question for Colorado is what were the realized benefits of going through the fee-for-service to cost-based interim payment model or approach?
The huge benefits were districts not ending up in payback situations. When the last year or two that we were fee-for-service interim claiming, I would say about 50% of the districts were in repayment every year. And going back to a school district after the year ended and saying, hey, you owe us money back is not a fun place to be in. Yeah. And so this allows us to really keep a good handle on it, allows districts to know where they are. I think everyone's just able to track it a lot better.
Got it. Thanks. Another question for Colorado. Lots of questions for you all today. What was the quality of the cost reporting data like when you were initially transitioning? Did you have any issues with that, or was it pretty good?
So this goes back to when I kind of came on, so it's a little bit before my time, but we've adapted over the years. I believe when we first started, it was just Excel based. So there was more errors, but now we have an online system and it works great. And I don't know that it was terrible quality before, it was just a different format.
Got it. Thank you. Just kind of making sure that we're catching all these questions. Oh, okay. I see another one here for Colorado, which is whether you are considering moving away from zero claims given the new guidance from CMS, and they thank you for participating today.
Actually, no. We are looking to still continue claiming through the MMIS system because we still need documentation. We have a system that's running and it works. And so we are not going to change what's working. And also additionally, we have a legislative requirement for our state to provide information that we receive through the MMIS system. So for us, it doesn't really make sense to explore other options.
Got it. Thank you. Just seeing if we've got any other questions. If folks do have other questions, please feel free to chat them in. I think we might be at the end of ours at the moment. Last call for questions. Oh, okay. Sorry, another question. Do you use reported or audited costs to set the monthly rates? And is there an audit for cost settlement purposes?
Yes. So we use the reported, but I'm not going to say audited. We do desk reviews and comprehensive reviews. And every LEA goes through a desk review, and then about a third each year go through a comprehensive review. We use 3 years of cost reports to do the interim rate setting. And so the first 2 years, those are final. We've already paid the final payments, everything like that. So those would be final. The third year is the year we're in and making the rate setting. So it's the best information we have at that time. It could adjust slightly, but it doesn't change a ton.
Great. Thank you so much. Oh, it actually looks like we might have one more question coming in. It says, what has feedback been from the staff and students who are receiving services?
So I'm going to answer this on how I think it's coming. So in Colorado, with the reimbursement, we actually have state legislative requirement that the reimbursement dollars go back to health services. So from that perspective, it's positive because it does get put back into health services. It pays for salaries, it pays for additional providers in schools. It doesn't pay for a football field or anything like that. The top 2 services it goes into typically are nursing and mental behavioral health services. And if that's not exactly what they mean, I'm not sure. That's as much knowledge as I would have on providers and students.
Great. Well, thank you. And I say thank you in the chat. So thank you so much. I think we are, oh, sorry, there's one more question. One last question about how school-based services furthers your broader state Medicaid agency goals, if you can speak to that.
Sure. So with our program, I mean, just on how the reimbursement is handled, I think is a huge in alignment with our state agency and our state goals as a whole. We have a huge push as a state, not even our agency, just from the governor's office for mental and behavioral health services. And knowing that the majority of funds that districts are using with the reimbursement are going back to behavioral mental health, that's a huge alignment. I mean, anything we can do to help get children more services is in alignment with both the state and the agency.
Great. Well, thank you again for agreeing to be panelists today. I think we all learned a lot from what you've already done. I'm sure there will be some other questions that come out of this that we will do our best to pass along to you all. If folks in the audience have any additional questions on what you learned today or that you'd like to ask Colorado, you can please chat them in and we will answer you through the TAC mailbox. But in the meantime, I think I'll turn things back to Nicole to wrap up our session today.
Great. Thank you, Michaela. Thank you, Shannon and Olga. Just as a reminder, we do have some upcoming events. There will be a virtual meeting on the topic of providing an in-depth time study breakdown, as well as a case study on January 10th, as well as we'll be having a webinar on January 25th with getting started with Medicaid SBS for LEAs. Please feel free to reach out to the email list listed here on this slide if you would like to be added to the distribution list. Thank you all very much for joining today. The slides, Q&A, and a recording of today's presentation will be made available on the Medicaid.gov website. And we thank you all again for joining us.